Okay, these are my financial disclosures, the ones that are highlighted, or ones that are relative to the talk. So as cataract surgeons, we know that with glaucoma patients, we have certain challenges. And those challenges can be even more in patients who have previous trabeculectomy or tube shunts. Because of that, we need to be more thoughtful in our preoperative approach and have more skills in our intraoperative approach as well. Some of those factors that can pose potential problems are anatomical. They can be related to poor pupil dilation, where you have to have different maneuverings to open up the pupil. You can have an overhanging bleb that's obscuring the patient's view as well as your view of the cataract that you have to deal with. And sometimes with a tube, there may be issues relating to where it's positioned that you have to also address. Factors to be considering postoperatively do include thinking more about inflammation, which tends to be a bit more common when there are those extra steps that are needed. That inflammation can cause a problem with blebs because it can cause them to fail. Also, there can be post-op pressure spikes that you need to deal with in addition to need for more medications. There have been studies showing that even after a routine cataract surgery, there can be an increase in eye pressure with the patients have functioning blebs prior. So in terms of thinking about solutions and potential ways to help, one is we have to consider in the preoperative phase knowing that we need to take some extra time. These are patients that evaluations have to include looking at the prior glaucoma surgery to be able to plan, looking at the stage of disease, trying to decide, looking at the gonioscopy, if this is someone that might need some type of treatment in the angle, like if they have peripheral angle PAS, or if they need additional Migs procedures to consider coming off of medications or help their uncontrolled pressure. Additional attention to the cornea as well as the pupil. Important also is the discussion with the patient, making sure you set the expectations. These are patients that I make sure that I have them look at their visual fields. The worst case scenario is to have a patient have 20/20 vision in their central area and be disappointed because that fog they thought you would lift with a cataract surgery is still there because it was really their glaucoma. So I make sure I show them that in addition to talking to them about the potential risks of failure and potential extra steps that are needed in the surgery. In terms of deciding for IOL choice, now there are different things that I think about. One, the stage of the disease. Just because they have cataract surgery or have had previous trab or tube doesn't mean that they're not a candidate for advanced technology lenses. Looking at the stage of the visual field, looking at the ocular surface, and if they have astigmatism. And a patient here who had a previous long-standing bleb, I did a toric lens on him because he wanted to have less spectacle dependence. He was on 2 medications. I coupled it with a goniotomy trabectome procedure. He ended up having a beautiful outcome of less medications and also of good vision without glasses. But one does need to be careful about using technology of extended depth focus or multifocal in patients who have any kind of visual field loss that is encroaching on fixation, like in this example. Then when thinking about when should you consider Migs, my basic 3 factors are, is the patient not controlled? Is the patient on at least 1 or more medication? And is the patient, does they have on gonioscopy viable angle that I could be treating? If these are the factors, then I do typically just consider using a Migs procedure. Which Migs procedure can you consider? I have actually used quite a number of these, actually all of these, at some stage in these patients and found that they can have some type of decrease in pressure afterwards. So there's a variety that can be utilized. In terms of intraoperative, it's important to change your position if you need to avoid the bleb. There's going to be instruments going in and out, so you have to be flexible, which could mean that you have to change the position, sometimes extremely, of where you usually put your incisions. Also, if there's an overhanging bleb, this needs to be addressed. Sometimes in a pre-stage approach, I learned this technique from my colleague Leanne Herndon about using a blade to help excise the tissue and kind of slough it off of the surface and then excise it at the limbus, and this can allow for a much better view for the patient as well as for your cataract surgery. Then with tubes, sometimes the tubes are long and sometimes they need to be maneuvered around, or you can try to cut them. There are different approaches. One approach here is to make a paracentesis, use a Sinskey hook to stabilize it, then use an intraoperative forceps in order to cut the tube, and then take a Utrata forceps to remove it. Sometimes that approach is necessary when it's not necessarily in the way, but you're concerned about the endothelium, and this is an opportunity to cut the tube shorter. Postoperatively, there's need for considerations as well, because one has to be concerned about IOP spikes and also being very aggressive about treating inflammation. These are things that I mentioned can pose a threat to the bleb or cause other problems. So different techniques using NSAIDs or low concentration steroids and just being aggressive looking at the angle to make sure there's no PAS formation. So in conclusion, cataract surgery and prior trab or tube does present some challenges that we need to think about preoperatively and address intraoperatively. Those evaluations need to be more thorough and more thoughtful. Patient expectation is very important to establish so that they can also have good outcomes. And then Migs does play a very important role in terms of helping with eye pressure spikes in between, as well as decreasing the burden of drops and helping with ocular surface disease. Thank you.
Oh.